some other, and I'm just trying to figure out, I think under relevant articles, yes. Yeah. So I put in, some different, articles for you guys to look at service reference, because this is stuff that's not in your textbooks. So, you do need to peruse these, articles for test content, for that. AFM, West Nile virus, outcomes, and then transverse myelitis. So no, those are under the relevant articles folder. So yeah, we have a lot of alphabets today with ALS, PPS, WNND, also known, we'll get to that, and then AFM. So these are all degenerative diseases that some have a better prognosis than others, but they have degeneration as part of them. So there are some commonalities, and you should be able, when we talk about interventions, you can extrapolate and apply them. They're not, interventions within each disease are not necessarily just for ALS or just for post-polio syndrome. But there are those commonalities, so hopefully it will make a little bit of sense as we go through that. So we'll start out with ALS. I know the PowerPoint last week had ALS information. I just updated some stuff, so this particular PowerPoint has all the updated information. It doesn't have very few pictures of Halo and Liam in it, but it does have updated information. So if you need a baby fix or a puppy fix, go to the previous lecture and look at the pictures, and then rejoin this one later. But ALS, so those, many of you guys kind of came in at the tail end of the movie. There was so much so fast. So Sandro and Chris, what did you guys think of that film?
I mean, it was kind of insightful to see the family's perspective of it, as well as they were starting to contribute, especially as they started losing the ability to speak. Like, you can see the toll that it was taking on his family. And then the technology would update, and then, you know, like when you leave the type out on the computer, what are you trying to say? It helped, but then again, it would always deteriorate again.
Yes, yeah. So you have some upswings, a little bit of a plateau, and then there's another decline, you know. But yeah, I think exactly it does show a nice the effects, a nice job of showing the effects that it has on somebody's family. One thing that I will say regarding that particular relationship between Wendy and Stephen, Stephen is the gentleman who has ALS, his wife is Wendy, is he had the diagnosis of ALS prior to them getting married. And, you know, she knew what she was getting into when sometimes with these disease processes, especially degenerative diseases, and next week with spinal cord injury, you will see, at least in my experience, and Dr. O'Shea may have a different experience, but the statistics do show a very high divorce rate, and even though it's not a formal divorce, there is and I use the word abandonment, but that's really not the right word for it. It's this isn't the same person isn't what the gig that you signed up for when you started dating that person and started living with that person and started this relationship, and it becomes overwhelming because you wanted a So I'm speaking from a partner standpoint. You wanted a partner in life, not to be a caregiver. And that can be very, very overwhelming to people, and it often leads to separation of paths. And there gets to be quite a bit of resentment with families to people who choose to leave the relationship with that. And sometimes you as a therapist are really caught in the middle of that, and it is very hard sometimes.
The other thing that happens sometimes is, especially if you're a dual income family, is that your dual income then eliminates or causes you to not be eligible for certain funding and certain things. And so sometimes families will, or couples will split on paper because, especially in catastrophic illnesses, the person, the client, is eligible for more services or more things without the dual income if they're alone, and now they're not technically alone and not working, so they're unemployable and all of that. You get some different insurance options, different funding options than if you're, especially a two-income family with kind of lousy insurance. So the working class folks get it pretty hard there because high deductibles and all that sort of stuff. It's really important. So financially, sometimes people, and you have to make sure when you're treating folks with these catastrophic illnesses, you have to make sure that there's a social worker on the team. Even if it's just well, let me introduce you to this person, so when the bottom falls out, you at least have a name to a face. Lots of folks think of social work as, we need counseling on how to cope with this, and they all do, but they haven't gotten to that point yet. But sometimes they just need assistance in figuring out financial systems, figuring out housing systems, and how to adapt environments. So always be the first out of the box, or on the team if nobody else has mentioned it. To have a social worker, we always have social workers who just happen to stop by therapy looking for some random miss, right? Stop by, hey Tino, you stop by about 10 o'clock and pretend like you need something from somebody. And so then they put themselves in the situation, and it's sort of a coincidental meeting of the mind, where the social worker will hang out in the lobby or just kind of come through and start random conversations with people. Families think they're random. You have orchestrated, or the therapy staff have orchestrated some of that behind the scenes. But so part of it is you're a conduit, and that helps that the person, if the person is highly stressed, or the family is highly stressed, that negatively impacts all of the therapy that you're doing. So it's in your own best interest, our best interest, to make sure people are supported as they can be, need to be, and that changes violently week to week, day to day, month to month. So just keep your ear to the ground on that.
Sometimes I've had it where personality-wise, the family doesn't like the social worker, but you know that they need the social worker. So then, like Dr. O'Shea said, you're kind of, so you come with a lot of questions and you're like, okay, I used to go to my social worker, Karen, this is what we're doing, da, 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 da. Well, they never told me that in the session. I'm like, of course they're not going to tell you because I can't tell her that they don't like you, but, and so you are the gatherer of the information, so they're a resource for you then to be that person. But with regard to ALS, simply it's a disease process that affects the upper and motor neurons. So it's the connections between the brain and our muscles. Now, this is mostly older individuals. That's what's most Sullivan. We are starting to see a wider range of ages with that. We know that the family, there is a genetic predisposition for about 10% of cases. The rest of it is just like the movie said, random. Sometimes you just have the bad luck of the draw. It does have increased levels of glutamate. What the whole role of glutamate serves in this disease process is still unknown, and except for in the family cases, and they can detect things differently. But yeah, what is largely thought is that it's an autoimmune reaction, And then the autoimmune reaction interacts with the excess levels of glutamate and deteriorates the neuromuscular junctions and the connectivities with that. And it is, from a motor neuron disease standpoint, it is the most common, but they're getting better at lab detection. So when in lab, it's not like they can do draw blood and, oh, you have this marker. It's genetic testing, and they are getting better, and there are some promising tests out there in animal models at this point, but nothing in humans, to show that they're looking for specific enzymes or different other cellular markers. But that, however, EMGs and nerve conduction velocity tests can be helpful in determining the cause. But it is a disease diagnosis of through the process of elimination. Many times they will say that this is acute demyelination, because the EMG will say that. And or they will also sometimes do imaging of the spine, and of course we're dealing with older individuals, so everybody has some stenosis. You must need a cervical fusion, you must need a lumbar fusion, even though the person has foot drop. Well, of course you have a positive radiology finding, so they put those two together. A person will go have a cervical fusion, lumbar fusion, and not get better, but get progressively worse. So there's a quandary with that. Oops. Okay, I don't know why this is not working. Oh, good Lord. Well, those of you who were earlier today, you know I'm having trouble with technology. So, literally, this means no nourishment to our muscles. So if you break it apart from the Greek components, A is negative, so no. Myo is muscle. Trophic is nourishment, so no muscle nourishment. Literally, is derived from the Greek components of the word, and it is in the lateral spinal cord where this is where the motor neurons get their nourishment, and due to lack of nourishment, and it does have scarring. So sclerosis is scarring of those areas. That's where the autoimmune component is thought to. So if we have prolonged inflammation, right, then we tend to have development of scar tissue laying down there. So that's where the autoimmune component comes in, and but of course still a lot of research too. So with that scarring of those lateral components of the corticospinal tract, what are we seeing? And and this is just animated. So the upper motor neuron damage results, we have weakness, just like we learned when we think it's an upper motor neuron lesion, we're going to have atrophy, right? So you might see some atrophy. The most common place you'll see a lot of initial atrophy, and it's often confused with carpal tunnel, is in the hyperthenar eminence of the person. The person will complain that their grip is getting weaker, and you will see some atrophy within the hand muscles. Oh, and of course they're going to say, oh, nerve conduction, you have a carpal tunnel. So there's often some misdiagnosing going on there with that. You can also have some spasticity. We know spasticity is an upper motor neuron lesion, and hyperreflexive components. But then we also have a blend of lower motor neurons, which, muscle wasting, twitching, so little fasciculations. A lot of times people will complain about muscle fasciculations after some strenuous exercise, and they're like, oh, I just got restless leg syndrome. So weakness and diminished reflexes. So your person can present with hyperreflexive and diminished reflexes. So upper extremities may present different than lower extremities with that. Bulbar region. Last week, did you talk about bulbar involvement with MS? You guys remember?
I don't think we specifically
So, well, this from if we go back to last week, once, bulbar region, is our speech and swallowing. It typically in MS, starts not so much with relaxing remitting, but when it gets converts to a secondary progressive, you may see some bulbar involvement. And it is a definite sign if the person started saying, oh, I'm having trouble with swallowing, or I don't feel my speech isn't, they notice some speech changes. They may be in MS, sometimes people are in denial of things. But if their family member notices it, it typically is a sign of a progression of MS disease. But in ALS, a lot of times the bulbar region will also become involved, and so speech becomes difficult. Just like Sandro had shared with us his take on the movie that we saw. Yeah, it was a big thing, and I thought Stephen in the movie said something really pretty profound. But I have been guilty of this, but he's like, yeah, I know they can't understand my speech. I'm still speaking. They go, oh yeah, and he's like, I know they have no idea what I just said. You know, and so you know, I think I got this movie like 6 or 7 years ago, and I thought, oh my God, that was me. I was like almost mortified about, oh my God, this terrible therapist. And because I had done that, and actually I had one patient call me out on it. She's like, what did I say? Repeat it back to me. And I'm like, oh, you said this. She's like, no. It happens to the best of us. And my advice to you is don't be a Mary Jones and try to, be embarrassed and lie about it. Is own up and say, I have really no idea. Can we communicate something? Can we write it? Can we point? Get another means. Don't be an a-hole like that. Because I'm pretty sure my patient thought I was a real a-hole. So anyway, but if we start seeing bulbar involvement, this becomes really important for you. If there isn't a speech therapist at this point, then you need a speech therapist. Because with this particular disease, it is going to progress. And just like Lisandro had said to us and shared with us, they have the different devices along the way that seem to help. And that's promoting somebody's quality of life, not only for the patient, but also for the caregivers, because we do have need that essence of communication between them. Bigger thing is nourishment. They're not going to be able to chew, so you might have to have dietary changes. So going from solids to puree to different, food consistencies. Whether they can use a straw or not. Do they need to use various strategies with chin tucking or, and the chin tuck is different for somebody with swallowing than it is for our cervical retraction. So cervical retractions we use for neck pain are not the same as a chin tuck for speech. So 2 different methods. And did you guys notice any strategies that Stephen was using during the movie when he was talking, how he was talking? Okay. So this is only because I know. But if you paid once I say it, you guys will know, but he would tilt up and then talk. So that's a strategy that's very commonly, because what happens then is when you tilt back up, you have some laryngeal closure, and you can then announce your words and pronounce your words better. So that is a strategy that sometimes the person will use to communicate. And it's almost like this strategy that they develop, they're not necessarily taught it, but if you see that person kind of doing that, you're like, you need speech on your team for that. Spinal cord, lower motor neurons are affected, so you're going to lose function in your trunk, your limbs, upper and lower. Head control becomes a strategy. So sometimes those are some very basic. So you're working on positioning, you're working on orthosis to keep to prevent contractures. Your seating and positioning becomes, and when we get into more in depth to assistive technology, you know, the thing is, you need, as therapists, to be on top of that, because it takes so long to get some of the devices and equipment. And by the time, you really have to almost have this crystal ball to look in the future, and, because you know what's coming down the road, because you have to order that ahead of time. So this is basically some visual representations of what happens between the nerve and the muscle junction, and when we don't have the nourishment, then we get atrophied muscles. This is a newer theory in ALS, where the neuromuscular junction, this, and I don't know, maybe you can see it better on there, but this little it's almost like a little glue substance, enzyme, that holds, or that's in that neuromuscular conjunction that maintains that connection between the nerve and the myofibril. However, in ALS, that is lost, and so then we have the separation, and no longer that nourishment component making that connection between in that neuromuscular junction. So that's a new theory, and they've been working on developing that as well. So it's progressive degeneration with the motor neurons, specifically our corticospinal tract. So I went ahead and put in just get used to seeing these tracks, because we're going to spend a lot of time with them in the next couple weeks, because we're getting ready to go into spinal cord. Anyways, but if you can kind of like really memorize corticospinal tract now, then you don't have to do it next week or the week after. So maybe a little bit of that. But we know that it starts back here in the lateral section, the anterior horn, and then we descend up and we go through our pyramids into the medulla. We know the medulla is really an important component of things, so we can see how respiration and other vitals can be impacted once we have some issues going on in the medulla. Note that this is where it depositates from the pyramids into the medulla. So at that deposition point, remember the importance of deposition points? Okay, so if there is some scarring there, then that's why you sometimes see upper and lower motor neuron presentations. Okay, and then of course back up into the midbrain, into the peduncles, and then up into the precentral cortex. So things that aren't affected are involuntary muscles. So the GI tract, bladder, so they remain intact. Okay, voluntary eye muscles. So a lot of times that ends up being the modes of communication, whether for that's driving their wheelchair or a communication device with that. Bowel and bladder control, sexual function, senses. I think in the movie, one of the things Steven said, they said, well, what do you regard me like not making a porno movie or something, or not enough sex on tape or something along those lines. So he maintained his sense of humor, largely sense of humor remains intact, but sexual function remains. Senses, so they have vision, hearing, touch, and then their cognition remains intact. And I think that probably the people that I have treated with this disease, their cognition is very much intact, and they are able sometimes to plan their progression out very well, and they have barriers of family members who just go, oh no, I had one patient who he had his disease process, and we had seen him, so it was maybe a total of 6 months, and once he got his diagnosis of ALS, he essentially, I don't want to say he gave up, but he was like, he was firmly in the mindset that he did not want to live like this. He was a very successful collegiate athlete, went on after in his adulthood, was always athletic and stuff, and he pretty much was like, there's no way I want to be on a respirator, there's no way. But his family would have told you something very, very different. in the movie that we just saw, Stephen wanted by any means to remain alive. So he was willing to make a compromise. It's very different journey for every single person that I've treated with this. Sometimes in the early stages, when they don't have a definitive diagnosis of ALS, and which sometimes can be going on, you as the therapist clearly go, oh, this is ALS. You cannot tell the person, I think you have Lou Gehrig's disease, you have ALS. And that becomes very, very tricky. And that is where your relationship with the physician, the neurologist, your social work, your support system becomes really important. I had my one patient, Ray, came with a diagnosis of Guillain-Barré. And it was not Guillain-Barré. And I really, I did say that it was, look, I think you have a pretty bad disease process going on. But even with Guillain-Barré, and I kind of danced around, I'm like, well, your recovery is just really, it's just not, doesn't fit the usual time frame of what you brought out else. But, this is what we can do for these your symptoms. And he was, when I first started seeing him, it was extremely important that, and he was a pretty well-known attorney. Where he had to go to court and stuff, he was currently just trying, working behind the scenes, handing off his cases. Somebody else was doing his court appearances, but he was behind the scenes. And he did not want to be seen in a wheelchair. Absolutely not. And they had, so he'd come to therapy, he was totally dependent with transfers, in a transport chair that you would get at like Walgreens. Like ours were like the ones in the room were like the Rolls Royce compared to what this guy had. And and as a therapist, they're like, you're mortified. And so, but my first treatment session with him, I brought up the seating and positioning, and they went to my manager and asked to see a different therapist. Because of course, my boss was like, Dad, you need to stay with Mary, but so she didn't switch him right away. She said, maybe next week after we do round, we can switch your therapist. Well, and realizing that, okay, he just did not want to hear it, I had to take a very different approach to, in the end, the catalyst to him being accepted and him accepting a wheelchair was that I helped his wife and his daughter, who was in law school, and his law firm had a pretty big social event. I said, why don't you just take a loaner chair? Because people really want to see your dad. And his partner in his law firm was like, yeah, Ray, everybody wants to see you. And so he was able to go to a social outing within his peers that demonstrated acceptance to him. And even some of his clients were like, no, I want you on my case, I want you. And it reaffirmed his identity. And so then he was acceptant of getting a wheelchair, thank God, because he would have had these terrible wounds. But anyway, and he had a diagnosis of acute demyelinating polyneuropathy, is ACIDP, or AIDP is what was the diagnosis we were working with. It was about a year, probably 14 months later from when I discharged him, and he was an outpatient, and then he had a study to find he would have home health services. Then he finally got the diagnosis of ALS with that. And I had looked back, and I had kept in touch with the family. Sometimes people, sometimes you do just become friends with the family. And I went to his, then he had to have a benefit. So I had seen him at his benefit and stuff, and kind of, at that point, he had very hard time communicating, but he said to me, he's like, I should have listened to you way back on. I'm like, yeah, I go, I'm not always right. And I said, I didn't want to be right about this, but he's like, but in the end, he was very appreciative and family was very appreciative of the step-by-step process of helping him, getting him the equipment that he did need and so forth. So just know that it's a long journey and sometimes you as a therapist have to be on your toes and know if somebody's not progressing, there's a reason why. So signs and symptoms, fatigue, loss of exercise tolerance. A lot of times there is some trends that show people who are pretty high-level athletes. I would say every single person that I have treated, unfortunately, who has ALS, has a pretty significant athletic background. That's just my experience. But like Ray that I just told you about, had done triathlons and was a pretty big member of the running community, multiple marathons. So some high endurance exercise athletes. Mike was a collegiate football player in college and then subsequently continued all his athletic endeavors. We most commonly know ALS as Gehrig's disease, again, a high-level athlete. Other high-level athletes also have acquired ALS. But by the times, 80% of motor neurons are lost is typically when we're getting a confirmation of the diagnosis with that. Again, you might see some variations of upper and lower motor neurons. Asymmetrical weakness, so sometimes right side's different than left side with that, and most commonly it's the distal areas, your feet and hands are most commonly affected first. The other thing that you may start seeing is, especially in the shoulders, any subluxation. So in particular with Guillain Barre, post-polio, ALS, I always keep want to make sure if I notice over time that we did have a subluxation and now we have a subluxation, I consider that a sign of progression. So that this tells me some other things. Foveal onset. Now I went into a little bit of that earlier, but we have definitely you can have weakness, but you can also have spasticity within the muscles that are innervated in a lot of the cranial nerves. So your trigeminal nerve, your facial nerve, hypoglossal nerves, the vagus nerve can sometimes become involved as well. What do you think the implications of the vagus nerve would be? What?
Breathing.
Breathing, but the heart rate. So sometimes you have to be aware of any unusual autonomic responses with that. So taking these baseline vitals remains pretty important, and monitoring their tolerance during your treatment. Typically, they don't have any pain. Do know that I put quite a bit of notes regarding speech and the laryngeal reflexes and things in the notes section of the PowerPoint. So PowerPoint's not a PDF, so you should be able to access those, right? Okay. So I just went ahead and separated upper versus lower motor neuron function. One of the things that is often with lower motor neuron dysfunction, besides fasciculation, is they will complain of cramping quite a bit. And this becomes a little bit of a quandary for you as a therapist because they're like, they just want to be stretched to no end. But however, if you keep stretching it and can make them hypermobile, you might be losing some proximal stability for ADLs and their functional mobility with what they have left. So that also becomes a bit of a quandary, but they get pretty significant relief from some aggressive stretching from the muscle cramp. So presentation to be real tricky, and I would always, I kind of go in the middle of that with some, I don't like the stretch to beyond, I mean, you'd be surprised, you're just like, oh my God. And so educating, the family, who's doing the stretches, because the patient will be like, go further, and you're like, oh, okay, maybe not. So, do know that you have presence of abnormal reflexes. So typically you're going to have a positive Babinski, Chaddock's sign. Are you familiar with Chaddock's sign? So Chaddock's sign is you take your reflex hammer and you scrape from the lateral malleoli along the side of the foot, okay, and you will get the big toe will typically extend. And that is significant for indicating that the quote-unquote-spinal tract is definitely involved with that. And then Hoffman sign, do you remember that lifting of the middle finger and the thumb will come in and touch you. So in Babinski is you reflex hammer along the bottom of the foot and the toes, abnormal response is toe splaying. And normally the toe will go down. So, and I did put notes on it as a reminder what those signs were. Yep. Sorry, Chris.
About the stretching?
Yes.
It's not what you
You're
absolutely
saying
not.
to be aware, we're the overstretching?
Yes.
So, can you guys just explain that practice?
Yes. So the person has muscle cramping. And so they want to stretch, they feel some temporary relief. But if I take away, because remember we have neuromuscular junction issue. So if I continue to lengthen that muscle, I'm in, they might have a little bit of spasticity, and they need that proximal or that spastic tone to maintain function. Because otherwise they're just gonna be a noodle. And so if I can, even if it's a cramp and it's uncomfortable, if they wanna maintain function, I need the muscle to have some tone. Versus if you continually overstretch, like for example, I mean, I don't have that much range, but it would not, this one patient had a lot of shoulder pain, they would be stretching this guy way up here, or even like, what is going on with that joint? And then you're gonna have additional subluxation, because I know a month from now, this muscle's gonna be weaker. Okay, so I try to preserve as much as possible. So you just don't wanna, because they'll wanna spend the whole session stretching too, and you can't just bill for that. So sometimes it's billing too, but just be careful to know that if you're creating some hypomobility, because then you could actually end up damaging the joints, because they just don't have the muscle strength around that capsule to maintain the joint integrity.
So it's not ligament laxity or anything?
Well, you can no, not truly. It's the muscles around there. Ligaments are bone to bone, but you have your tendons and all that.
And then is the cramping a result of the spasticity, or is that related?
Yes and no. The muscle cramping is just an abnormal sensation, so they're getting, the muscle junction is not operating correctly, and so it's getting intermittent signals, tightening, not tightening, and it's just in a dysfunctional state.
But people with spasticity don't complain of cramping.
They still can.
Okay.
There's a lot of different descriptors out there, just like when somebody says they're dizzy, there can be a lot of things. You have to kind of investigate what that is. So diagnosing ALS, a lot of medical history, so how long has this been going on? When was the progression of the weakness? And then your neuro exam. Kind of the hallmark of it is if they have an upper motor neuron lesion and a lower motor neuron lesion on the same side. So that typically is note their MRI findings are final. They may have EMG and nerve conduction, muscle biopsy, but also genetic testing. And those are the twins. So again, it's kind of like, we'll test for all these other things and then exclude. I don't have it on the slide, but their spinal tap will be negative. Okay. You know, as opposed to beyond gray, we have a positive spinal tap, right?
What would you find in the muscle biopsy?
So in the muscle biopsy, the myofibrils will take on it because they've been atrophied, because they haven't been nourished for a long time. They may have scarring within the myofibrils, but they also will have a decreased diameter. So progression, yes,
So for the spinal tap, you're looking for infection?
yeah. So like beyond gray, they have positive,
Because it's caused by.
right? But in ALS, it's gonna be normal. So ALS, typically 3 to 5 years is the progression. Depending on when you actually see the person, is when they, your goals need to be, you gotta kind of keep that time frame of goals. After diagnosis, because keep in mind, they probably had the diagnosis a few years before they actually got their diagnosis, is about 3 years. So 20% live 5 years, 10% 10 years, and 5% live 20 years or more. Now, Stephen Hawking lived over 50 years with ALS. That's a very, very rare patient. Typically, it's the respiratory muscles that result in paralysis, and it becomes the means or cause of death. Otherwise, they have mechanical ventilation. But sometimes, pneumonias and other infections can find their way, and then they sometimes become septic, and that will be another cause of death or complication. Yeah. So who gets ALS? Well, typically men more than women. It's pretty diverse. It doesn't matter. There isn't an ethnic predisposition to that. But between 40 and 60 years of age, so younger than 40 is pretty rare. But that, most of it is random versus the familiar ones. So yeah, there are some people who have a positive family. They know the gene that is located on chromosome 21, SOD1, and it's an autosomal dominant with that. Medical management. So once this valvular involvement, once it happens, and respirations and things are soon to follow, there are 2 drugs out there which decrease decreases glutamate directly, and this extends the time basically before the person requires ventilation with that. In the movie we saw, I think it extends 3 to 6 months of life. They've gotten a little bit better at prescribing this, so currently it could be a little bit longer than that 3 to 5 months. But radicative is a free radical scavenger, and this is going along the thoughts of the autoimmune component to leading to ALS, and it's showing the neuroprotective effects and slowing the progression by going out and picking up these free radicals that are causing the damages that are thought to occur at the neuromuscular junction. So those are the 2 drugs that are currently there, and I put some additional information if you just want to explore a little bit further onto those specific drugs with that. There are clinical trials going on for development of that. So if you have a patient who is on a part of a clinical trial, then you just have to investigate what their plan with that. Just like, there's so many different chemotherapy drugs, and if you're going to see somebody who, you have to investigate what are the potential side effects and so forth with that. So in different disease processes, stage 1 is very early on. They may have some weakness and some endurance impairments. So you're teaching energy conservation, low resistance strength maintenance, range of motion, stability exercises, and so forth. Stage 2, yeah, there's definitely atrophy of muscles going on at this point. So you know that this isn't going to be restorative type of techniques. So you're going to try to maintain their level of function or help them develop compensatory strategies. This is often where you might start prescribing an AFO or a hand splint, those types of things. So with stage 2 in particular, and we saw in the movie the use of a soft cervical collar to help with head positioning. You know, our postural muscles, they become significantly weakened and impacts their seating, but also head control, which is important for communication, engagement, and or operation of their assistive technology. Like that. So stage 3 progressive weakness, this is when all the axial muscles, so your shoulder girdle, your pelvic girdle, your spine really becomes deteriorated and compromised. And so you're really dealing with a lot of compensatory strategies, and this is often the utmost important that you have thought about stage 3 before, while in probably in stage 2, so that you can have proper seating devices for them accordingly. They will need a wire level. If they're going to do standing activities, they will need a stander, a fully supported stander with that. And then stage 5 is totally ADL dependent. They may have a tracheostomy, a ventilator. G-tube is definitely needed for nourishment with that. Now, you may have a patient who has refused trach and G-tube and stuff, so then you're pretty much looking at palliative care for that individual. So the impact on function, as you mentioned, decreased endurance with that. So very light exercises. This is a group of patients you do not want to over-exercise. So prior to, right now we're thinking of neuroplasticity principles, repetition, intensity, and stuff like that. No, we're not going to get any neuroplastic changes. Remember, their brain is totally intact, right? That's not right. This is all extremity function. So if we overtax those motor units and things in their muscles, we're just kind of blowing out the system early. So very light exercise, aquatherapy, range of motion, walking, energy conservation becomes really important with that. Stretching for the cramping, but not becoming part of surface dissolate. That they can't have another career in surface dissolate like that. So with dressing, comes, a lot of times this is helpful when if you have an OT, they will, Josh?
Sorry, I had a question on the last. If the conscious of the environment, like insurance, like with multiple sclerosis, I said you have to be conscious of the temperature of the environment.
No. Their sensation remains intact. It's really a pure motor. No, where MS can affect both sensory and So typically you have an OT who can work with somebody, but if you are the only person, then dressing the weaker side first. So which side do you have most difficulty with? Loose fitting clothes, putting on an Under Armour shirt is probably not going to be the best, the easiest task to do for that. Cross-leg methods of bringing your leg up to get your socks and shoes on versus if I'm losing axial skeleton and I'm bending all the way over, I'm not going to get up and stuck in a folded position. Keeping items within reach in the kitchen and things, bringing things down, or in the bathroom, having things all there. Really giving them take 2 or 3 minutes, take a rest, 5 minutes, take a rest, depending on the person's endurance with that. So, medications to decrease symptoms. You know, if the person's having a lot of spasticity, they may give them some oral baclofen to help manage and provide comfort with that. Respiration management. So, if you're in a hospital team, then there should be a respiratory therapist there to help you with that. It's very important between you and respiratory therapists to know, do they need suctions and do they need different airway clearance techniques. The other thing, there's an intervention called stacked breathing, where you use an ambu bag, especially in the later stages, to preserve the muscles of respiration as best as can. But that might be something that respiratory therapy teaches you to integrate into your intervention, your plan of care. But it's also that you have to teach the family members on what to do, because you don't go home with the patients a lot of times. So, you know, when we were examining, you know, getting that history of like how long have your symptoms been going into things, it really gives you an appreciation for that, the disease progression and where you're going for that. And, you know, global muscle function and ADL, depending on how much team, who's on your team and what support. And a lot of times I like them to add, to keep some type of log or an activity, so I know what their endurance levels are. What are they having the most trouble with? Because then that's where it helps you hone in on it with them. So, mini mental status. Sometimes that's helpful, especially in the older generation. You're getting an idea for their global understanding of things, or where that. But depression scales. Again, maybe your social worker teammate can help with detecting depression. There is a specific ALS quality of life measure that you can use, but pain scales, the dynamometer, manual muscle testing. If you're looking to track disease progression, the dynamometer works much more accurately than manual muscle testing. With that coordination, are they able to initiate? What is their time that it takes them to do the heel, the shin? Often they will be accurate with that coordination, but how much time? So is it a slow mark? What is their Ashworth scale? Cranial nerves, HOMA, Berg, or TUG. Now, this is one disease where I do have a bias as a clinician. I will use the Tenetti or the POMA for that. There is one study out there, and it has not been duplicated or something, but it showed a correlation of if they scored certain score, then within 6 months they were predicted to need wheelchair mobility. So if I'm seeing something very early on, you know, if I know that they have scored say on the POMA 19, I need to get on my wheelchair, seated in the positioning from the get-go with that. There's, like I said, it's a very small number. I think they had like 6 or 8 subjects in the study, but it's the only study that's out there and it has not been repeated. But it's, so I think that gives me more information, because it also gives me some general balance, but also their gait information. So do I need AFOs and different types of things for there. You know, the TUG is a quick measure, but I would do the Tenetti over the Berg in this particular population of that. What is their gait looking like? A lot of times the gait, again, they're not, they tend not to be ataxic, but they're very slowed, and their postural involvement may make them very lenient on a walker. And if it is something that the person wants to continue going, this is where you're going to be like, do I need a bilateral platform walker because they're going to lose hand function, and then this, so you need to adapt the walker into that. What is their respiratory status? I will take a circumferential measurement of their breath expand. Are they, how much excursion are they going to be able to get? Because if I notice that they're losing a centimeter in, breath intake, excursion, I know I'm having problems. They're a risk for pneumonia and very negative sequelae. Also, that means if I notice that is a decrease, then I also need to teach them, respiratory exercises, and I might need to flutter valve, and so it brings in some other areas of that skin. How often are they moving? You don't want skin breakdown. Skin breakdown is going to lead them to sepsis. Okay. The FIM measure, if you're inpatient, is helpful at times because it tells you how much assistance they are having with that. So, a lot of times, very, very early on, stage 1, you may have a shot for a short period of time, 6 to 8 months, of actually having a restorative type of goal. Otherwise, you are always in the prevention mode. You're always trying to prevent the onset of pneumonia. You're always trying to prevent the onset of skin breakdown. You're always in the prevention mode of trying to prevent fractures. So those are always, and then compensatory is like, okay, now your gait is changing, now we need to get an AFO, or you might need a knee cage, hand splints, so forth. Disuse activity, you want to also educate on overwork. A lot of times now, if typically, like I said, I always dealt with some people who are highly athletic, and it's very hard, because you guys all know what a runner does when they're injured, right? Or they go run, of course. You change your shoes, you get a new pair of shoes because the shoes are gonna fix it, and then you go run. That's just what you do. Same kind of mindset goes on here. I need to get better, and whether that's a coping mechanism of still being part of denial of being able to do something with that. So, and then know what stage you're in that will help help you formulate your goals. And I gave you a lot of information in the notes regarding goals and some thoughts on that. And then we have, during the early stages, we went ahead and said, okay, what are these common impairments that you see here? And then what are you going to do for restorative, preventative, and compensatory? So here, we're even thinking if they're at workplace, do they need a workplace modification? For Ray, getting him actually back to his office in a wheelchair so that he could do, but then modifying his computer, so assistive technology, because he had some significant atrophy in his hands, using voice command. So he was able to use Dragon Speak quite a bit to maintain him doing his legal briefs and so forth. Education, and educate, re-educate, educate some more. Our patients, family members, and even other healthcare teams. This also, I guess, you could put in there communication back to the physician on what the progression is as well. So in the middle stages, you're going to see progressive decline in mobility. Definitely wheelchair usage decreases during this time. They may have some pain starting in the middle stage, and that goes to, if they were self-managing via a lot of stretching, now they're going to have joint pain. So in the deciphering is what the pain is. Sometimes it can be a little bit neuropathic too. And so we're going to continue with stretching, strengthening, pressure reliefs, positioning, orthotics for support, modifications at home, and wheelchair usage. And then in the late stage, a lot of palliative care comes in here, maintaining respiratory function. You may need to do chest PT to get secretions out. So all the stuff you learn, how to drain the lingua, remember all those positions? Okay, a typical board question might be that the person is in the late stages of ALS and you hear some, that they need help with pastoral drainage, and so if you have the lingua, what side are you gonna position them on? This would be an application of, blending two things together. So do you know what ALS is? You know your anatomy of the lingua, and know that that's on the left side, and you need to position the person on the right side and their head down because you're doing postural drainage, because that's a the lower lobe. Okay. So just to kind of give you an example of a complex board question that might stem from knowing your stages and knowing that that is prevention of onset of pneumonia. So that is ALS in a snippet of that. Do you guys need a stand-up? It is a syndrome that happens after polio. So, and it was first, that's pretty largely discovered. So, kind of going, we actually need to go back before 1970. So in the 40s, polio, in 40s and 50s, polio was an epidemic. So people acquired polio, and then they sometimes got better, if their respiration, muscles of respiration weren't involved too much, then they would get better. So they made their recovery, and then around 1970, so 40 years later, after they had childhood polio, they started experiencing some significant weakness or a decline in function, versus what previously worked for these folks just was not working. There's a very wide range of statistics there. 20 to 40% of people with polio had some significant weakness develop 30 to 40 years after their onset of their original illness. And it was a combination of some neuromuscular, psychosocial, and musculoskeletal involvement. So it's this wide range. But however, most commonly was they started noticing their musculature become flaccid and having new paralysis. Or their active range of motion was now limited. Also, they used to also complain of significant fatigue and deep muscle pain. With that, which contributed to ADL, work, and social limitations. With that. So, regarding the new onset, the etiology, what happens, and why is there new atrophy is relatively unknown. But the thing is, the neurons may age prematurely and fail. So a couple of theories that are out there really will point to so in polio, they lost some motor neurons in those. And so instead of having 10 motor neurons, say, in the muscle, you got polio, now you only had 6 left. So those 6 muscles hypertrophy to do the work of the 4 that you lost, okay? And so now they are kind of been working overtime, taking up the slack for those motor neurons that you lost, and they simply become burned out. So now you had 6 muscles that were optimally working, and now you have 3 left. And so that's your new onset, because you lost 3 more because they burned out, they died of exhaustion, essentially. So that's the most accepted theory out there. There is also a theory out there that maybe an autoimmune component triggered those, a new viral component, and it started attacking the remaining motor neurons. And because we know polio comes from an exposure to a virus, it is within the gastrointestinal system that it modifies It can replicate without messenger RNA, and it goes through the body, and so there was a thought with that as well. Nonetheless, they have less motor units than they initially had. So when the doctor diagnoses post-polio syndrome, they have to have a documented history of polio. Now, there are a few exceptions. Back in the 80s, exposure to the live vaccine. They haven't used the live vaccine for polio since the mid-80s. But there were some documented cases of somebody acquiring polio from fecal contact after the live vaccine was used to, that's how polio is spread, is through bad sewer systems and through fecal contact. And so some people, like parents changing a child's diaper, the child had received a live virus, a live vaccine virus, and they had exposure to it and acquired polio. So there are some very rare cases, but that's where they've traced it back to. And that's one of the reasons why they don't use a live vaccine any longer for that. But during diagnosis is so partial and complete muscle strength and recovery. So you had polio, you recovered, you were doing well, and now you have this new onset with that. And also the onset of 2 new health problems. So a lot of times that is respiratory and cardiopulmonary as well. But no other medical conditions did. Right? So somebody who had a stroke probably isn't going to fit that characteristic that they have the stroke. So symptoms typically is fatigue. Sometimes there's muscle atrophy. They probably had some muscle atrophy from their initial case of polio. But sometimes they're variant, like, oh no, for example, one gentleman that I treated, he clearly had muscle atrophy because his AFO no longer fit. I mean, there was that much atrophy that I said, oh, well, yeah, you atrophy. That joint pain, a lot of times because you have muscle weakness, and if you have muscle weakness and you're hanging on your joints, if your joints are taking the brunt of these forces. And then scoliosis is a common musculoskeletal compensatory compensation because of axial skeletal muscle weakness, proper alignments as well. So when your person comes in for evaluation, you want to know what is their history, especially orthopedic surgeries. A lot of times people have a history of various orthopedic surgeries early on in their childhood, so you may have to dig back into their history with that. You want to do manual muscle testing, range of motion, what is their specific physical activity, and how has this new onset impacted that. Postural evaluation, you're going to see, this is where you really have to dig out your sleuthing, make your charts right versus left, because sometimes it's your left posterior muscle, but your right anterior, so you have a lot of different asymmetries going on, and then you have to sleuth together, well, what muscle compensations can I teach this person to do to make optimal movement. Know that when we teach compensatory strategies, they often have a sequelae of effects with that. So you're evaluating, especially if they're having some pain with their joints as well. Musculoskeletal evaluation. This is where you want to definitely make sure you're testing your ligaments and what's still intact. Because these people, we have normal aging going on, especially when you're starting talking into shoulder growth. Sometimes there's always been that partial rotator cuff tear. Now they have new onset of weakness. Now it's problematic with that. And then if they have been using orthotic devices all along, well, what are they using? Because these are people who are just they will sell their spouse before they will sell their orthotic that they've used for a long time. I'm being very serious. So you may see some leather upright kind of gadgetry. One of the most interesting cases I had was, this guy was at least, I think he was in his early 90 or 91, and he had, I think it was his right leg, above knee amputation. And he had the lace up corset and everything, the most basic knee and ankle joint and foot on that you could imagine. And I don't know what the fuck just was thinking, but they thought they were going to order him like a new fangled knee or new prosthesis with like the computer knee. Oh, it's gonna be so easy for him. I'm like, he's 91, he's not gonna learn how to walk with that thing. He's got a motor pattern, he's motor learned. And then he had like a stroke on top of this. You're like, really? You want me to teach that? He put up such a stink. We had to get a tailor in to fix the leather, like a shoe guy. And he ended up being functional within the house, but it wasn't gonna happen with him. And here the prosthesis was like $80,000. It was not gonna work for this guy. So you cannot change. Do not go down that road. You're asking for your own headache, and then you'll be like 3 weeks in and you're like, what was I? So, but yeah, that's definitely something. Dr. O'Shea may have hit. Well, with the littles, they don't really. What about the little? They don't really have that much commitment to their devices yet. but older folks who have used it for a lot of years, just trust me on that. You don't need to.
Your polio folks too are very stuck in their ways. I mean, they're edgy, they're irritated, some of them are very pissed off, just like Mary said, that they thought they had really beaten the disease and now it's back. Okay, so you have to take all of that and their anger with a little bit of a grain of salt. Yeah, they know what they know, and it will bring you back to history with the stuff that they roll in with.
Yeah. But, if you like to, whenever I'm at a museum, I always like to go to do they have any medical devices? The sick thing I like to do. But anyway, if you ever go to Gettysburg, Pennsylvania, a lot of the Civil War, go to the Civil War Medical Museum. You'll see the most interesting things.
You actually go downtown, you don't have to go to Gettysburg.
But you're not gonna get cool pictures with orbs and things and like ghosts and pictures.
Right down on Michigan Avenue, there's the surgical museum, where you can see all sorts of crazy things. And they go to the doctor.